Welcome, everyone. I am Ashley from the Vasculitis Foundation. Today, we're going to be talking about pregnancy and breastfeeding with vasculitis. We've got two special guests who will introduce themselves in just a moment. But before we do that, I just want to do a little bit of housekeeping and then we can jump in. The first thing I want to let you know is that the chat is open. If you want to engage with each other, or with us during the webinar, please go ahead and put any comments you want in the chat. However, for questions, we're excited that Dr. Sims and Heather will be taking your questions live at the end, towards the end of this webinar. So if you have specific questions you'd like them to answer, there's a Q&A box. You can find it at the bottom of your screen, these little like quotation box things, and it says Q&A. So throughout the presentation, if something comes up for you, a question, go ahead and put it in there and we'll try to answer as many of those questions as we can at the end. I guess the last thing is just we're able to provide these webinars for free to all of you thanks to the support of our partners, AstraZeneca, Novartis, and Amgen. So we're grateful for them for making this possible. And grateful for you all for giving us your time and attention today. So with that, I'm going to let Dr. Sims and Heather maybe take a couple of minutes to introduce yourselves. Dr. Sims, why don't we start with you?
Yeah, so my name is Catherine Sims. I'm a rheumatologist located in North Carolina, and I have been working with the Vasculitis Foundation for about 4 years now through the Vasculitis Pregnancy Registry, which we'll kind of talk about towards the end of today. But I'm a rheumatologist who specializes in reproductive health, and that spans cervical cancer screening, pregnancy, breastfeeding, menopause. So I'm very interested both in research and clinically women's health issues within the world of autoimmunity and rheumatic diseases. So thank you for having me. I'm very excited to be here.
We're excited to have you and your expertise. Heather, why don't you go ahead and share a little bit about you?
Yeah, so my name's Heather. I was diagnosed with Tachy osteoarthritis in 1997 at the age of 13, and I've been living that life. I don't really know much else, and I was fortunate enough to have two amazing baby boys. One is 5 and the other just turned 1. And I am a patient research partner with the Vasculitis and Pregnancy Registry. So I'm always excited to kind of share my journey, not only with Dr. Sims and the other research partners, but also with other patients to kind of encourage you on your journey and how to kind of navigate this, which is a fun and exciting time for a lot of us.
And one of your sons was on camera before, almost going to be one of our co-hosts. So we'll see if he wants to make an appearance.
It's very possible. It's very possible.
So I guess I'm going to dive in with you, Dr. Sim, just as this first sort of like grounding question is it possible to, I mean, Heather's an example, but is it possible and safe to have, to get pregnant when you have vasculitis?
Yeah, and I definitely agree that Heather's perspective is going to be really unique today. I have learned in working with Heather and other patient partners that there's two experts in the room when it comes to these conversations about pregnancy specifically. So as a rheumatologist, I have textbook knowledge of vasculitis, but as Heather said, she has lived this life since 1999 or 97?
97.
97. Okay, I can't miss those 2 years. And so having her expertise of knowing her body, knowing her condition, knowing which medications work for her is critical in making that decision with your providers. So what I tell patients is bring up the topic of pregnancy with your doctors as soon as you realize you want to get pregnant or want to start planning for that in your life. The more time your doctors have, the better, because we can assess your condition, any type of vasculitis you have. So how active is it? What medications are you taking? What type of organ involvement do you have? So is your heart involved? Are your kidneys involved? Are your lungs involved? And the reason those things are important is because it helps us as your medical provider to stratify or layer out the different risks that could be involved with the pregnancy, which is really our main role, is to give you the information so that you can make an informed decision about whether you want to pursue pregnancy. I will say in the majority of cases, my patients with vasculitis pursue pregnancy, do very well, are very happy. And they always typically have multiple providers. So there's normally a rheumatologist, a high-risk obstetrician, also known as a maternal fetal medicine doctor. And if they have other subspecialists like kidney doctors or lung doctors, we're often all working together, seeing the patient at least once a trimester, assessing your condition, make sure that it's still very quiet. And the reason that's important is because a healthy mom means a healthy pregnancy. So optimizing your health and taking care of yourself first is actually the best thing you can do for your pregnancy and for the long-term health of your child. So having those conversations early, talking about if your medications need to be switched to something different that's compatible or safe in pregnancy and safe in breastfeeding. These are big kind of pivotal moments in moving towards the direction of pregnancy. So giving your doctors about 6 months to a year to make those slow transitions will help to keep your disease as stable as possible, but then also make sure that your medications are in line with your own personal goals of pursuing a pregnancy.
Yeah, and Heather, I'm going to get to you in just a moment because I know you are a great advocate for like planning with your doctors and being an advocate and making sure the whole team is working together. But for the moment, Dr. Sims, can you talk about some of the big risks for people getting pregnant? I know I'm sure it's different for different people and different types of vasculitis. If you can talk about that and maybe some medications that might have to be avoided during pregnancy.
Yes. So I will start off with general recommendations for all people with vasculitis, and then I can kind of move into a few specifics just to give examples. So the patients who have the best pregnancy outcomes have planned pregnancy. So that's number one. So knowing you want to get pregnant, and if you do not want to get pregnant, being on a really good birth control plan so that you can control the timeline of when you conceive. So that's number one for anybody with vasculitis. The second is having quiet disease going into pregnancy. So what the data shows us is there's two groups of patients who have a higher risk of pregnancy complications, and that includes patients who are diagnosed with vasculitis during pregnancy, like they're first notified of the diagnosis in pregnancy, which is not anybody here, since we already know the diagnosis, but anybody who goes into a pregnancy with active vasculitis has a risk of increased pregnancy complications. And this is because that inflammation that is driving the autoimmune disease actually can impact the pregnancy development, and it can impact what medications you may need. So for example, if you go into pregnancy or you conceive while your disease is very active, your doctors may need to give you high dose steroids, something like prednisone, in order to bring that inflammation down as quick as possible. And the high doses of prednisone that we have to give you can sometimes cause complications in pregnancy. Things like delivering the baby early, having a smaller baby. Now, this is very dose dependent. So if somebody is on 40 milligrams of prednisone, that's a different scenario than somebody who's on 5 milligrams of prednisone. So the higher the dose, there's kind of this relationship. The higher the dose, the higher the risk of complication. So planning the pregnancy, having well-controlled vasculitis going into a pregnancy. The third is continuing vasculitis medications. So Heather and I are part of the Vasculitis Pregnancy Registry, and we just published 2 papers within the last few months of results of women who have gone through pregnancy, who went into pregnancy knowing they had vasculitis. 75% of those women required some medication to control their vasculitis during pregnancy. Even though they had well-controlled disease going into pregnancy, they still needed a maintenance medication to keep it at bay while in pregnancy. There's a lot of theories behind this. When you're pregnant, your estrogen and progesterone are rising, and there could be a relationship between hormones and disease activity in autoimmune diseases like vasculitis, which is why 80% of all autoimmune diseases are found in women. We think it's likely some type of hormonal interaction. So continuing your medications gives your body the advantage of constant low-grade inflammation from taking the medications consistently, whether it's an infusion or an oral pill. So what medications you should avoid or should not take? There's a very short list of medications. I would say the most important one is cyclophosphamide or Cytoxan, which is probably one of our strongest medications in rheumatology. I have used it for things like Takayasu arteritis, ANCA-associated vasculitis, in some of our most severe cases. So if I think that someone is going to go into kidney failure or they have a lot of bleeding in their lungs, then I may be more inclined to move towards something like cyclophosphamide. But there's been a lot of developments in treatment for vasculitis within the past few years, and things like rituximab, which are potentially you can continue in pregnancy, is a nice alternative to something like cyclophosphamide. So cyclophosphamide can hurt the development of the baby. It's known as a teratogen, so it can cause malformations. It can also induce miscarriages. But also it can impact your fertility and your ovaries, and that's a different conversation. But if you are interested in pregnancy and cyclophosphamide is being brought up in conversations with your doctor, make sure you voice to them that you may want to have a family in the future, and that's important to you. So what can we do now to preserve that ability to have babies in the future? Two other medications are methotrexate and mycophenolate. Methotrexate is typically an oral pill. You take multiple pills once a week. Mycophenolate, or it's also known as Myfortic, is another version of it, is a pill you typically take daily. And both of those medications can cause malformations in the baby. And methotrexate is actually something we use for ectopic pregnancies to terminate the pregnancy. So I always try to drive that point home that these medications are really important for vasculitis and for keeping inflammation low. But if you want to move towards conception, bring it up with your doctor so that they can transition you over to medications that can be just as effective but are safe in pregnancy.
Thank you. I appreciate all that information. Heather, speaking to what Dr. Sims is saying there, you've said to me, like, even for a healthy woman without vasculitis, pregnancy has its risks. And so you really wanted to go into this, planning this. Talk to me about what that looked like, the steps you took to plan your pregnancies.
So for me, because I was diagnosed so young, I was 13. So my parents had more control and kind of oversight over my care initially. And initially, Cytoxin was brought up. And thankfully, my dad had done research and knew the risks on fertility, and we had a community of other people with Takayasu's who had informed us that that was not great. And again, sometimes you don't have other options. But at that time, my dad was like, last on the list, if you guys can avoid that, we would prefer not to make fertility decisions for her at 13. That being said, you do have the option to do an egg retrieval. Again, not at 13, but once you're a little bit older, you could do an egg retrieval. There are things that you could do if that was your last option to still preserve your fertility. And so I think even if you're not ready to have a family now, it's important to go and also keep that in mind when you're speaking to your doctors and let them know, right? Like, we're not at that plan now, but at some point in the future, I mean, I wasn't married until I was in my 30s. And so, but it was always one of those things where I was like, I do want to have a family and get married someday. And so I want to make sure that like decisions we're making don't affect that. And that's not always something that is on their mind when there's like a bad situation, because usually by the time they get to Cytoxin, you're probably in a pretty bad way. And so it's good to really kind of figure out what you want to do before that comes up. So that way, if somebody was like, we need you to do Cytoxin, then you're like, okay, well, I would like to, either go retrieve my eggs or do what I can to kind of, I think you can, Cassy, can you also take medication that might be able to protect?
You can.
Yeah. So there's things that they can do still like on those medications that might be able to protect kind of your fertility. That being said, for my disease, I've been controlled with prednisone and methotrexate. And so when I got ready after I got married, actually, I think it was before I got married, I talked with my doctor and they had said 6 months, you need to be off of it. And so for me, I was like, I'm more comfortable if it was like a year, just because I wanted to make sure everything was out of my body and that I was stable. And so we kind of moved in that direction to offboard that medication. And again, I think I'm one of the few that's just on prednisone and I'm on a very low dose. But even with that, I did my due diligence and I went to go talk to high risk, like my rheumatologist recommended, and they were not thrilled to see me. And it was probably one of the worst days of my life, because I went in and I was like, my rheumatologist said, go have babies. And I was like, hey, I'm here, I'm pre-planning. And they're like, oh no, you should not do this. Like, the prednisone will cause all these problems with the baby. And I was very confused because I had other friends with Takayasu's who had babies and they did amazing and they had multiple babies, and my rheumatologist had supported me. And then there's this random man who's like, this is horrible. Like, did you discuss this with your family, the kind of risk that you're putting yourself at? And I was like, oh. And so I had to pull back, and that's when you have to make a decision kind of for yourself. And that's what Dr. Sims is talking about, is that I then had to really acknowledge the fact that, like, oh, I mean, I knew it was risky, but the fact that somebody was like, this is bad. And I was like, okay, well, why is he saying this? And the big thing for me is that I have damage to my carotid arteries, which puts me at a very high risk for a stroke. And so the high risk doctor just reads you on paper and they're like, yeah, we're not going to be able to make it through this. I have doctors who know me, who have followed me for years. And so I went back to my rheumatologist in tears, and I was like, they're telling me I can't do this and that I'm going to die and that the baby is going to, like, we're all going to die. And I was like, very confused. And she's like, well, you have to make these decisions kind of. And she's like, well, what do you want to do? And I was like, well, for me, because the stroke risk was the biggest issue, and what, I don't want to leave my husband with me either in some kind of a bad state or not here at all with a baby. I decided that for me, I needed to go clear this through my vascular surgeon who deals with my stroke risk, who knows me, knows my body, understands everything that's going on, and also my cardiologist to make sure that my heart was okay. The big things that might cause, that might be a comorbidity in somebody who has pregnancy with vasculitis. And so I went to my vascular surgeon. It was the longest month that I had to wait for that appointment. And I went in there and he's like, yeah, like, he's like, you're fine. Have as many babies as you want. Like, he's like, I can't give you like 2 big thumbs up, but he said, I can get you through this. And that's all I needed from him, was like, I understand that nobody's going to put a big smiley face and be like, let's go do this. Everything's perfect. Because again, even for a healthy person, pregnancy is just a risk. It's a risk to the mother. It's a risk to the baby. It's just how it works. And so he said, we'll get you through it. And I was like, that's all I need from you, is just somebody that's like, and I told my husband, I said, that's the deciding factor. And it may be that we go to him and he's like, I'm sorry, you're going to have a stroke and we can't support you. And it would have been really hard, and we would have had to find another avenue, whether it was adoption or possibly surrogacy or something, to, if that's really what we chose to do. But I knew that he was the person that needed to make that decision with me and needed to give me the information to make my decision. And I think I've told Cassy before, like, by the time I come to you and I'm like, I want to have a baby, it's not really me asking you permission. It's me asking you to inform me what my risks are. Do you think you can carry me through this? Do you think my body is at a point that, like, we can manage this? And am I as safe as I'm going to be? Because again, I'm not a perfectly healthy person. I know this is going to be rough. And I had 2 amazing pregnancies. Both had different challenges, a lot because of my vasculitis, right? I don't have blood pressures that they can monitor properly, and that freaks people out. And it was not easy. I had friends who were pregnant at the same time. I was in the doctor way more than they were, which was amazing because I saw my baby pretty much every week. But at the same time, like, you have to be prepared. I was fortunate I work for good companies that allow me the time off, because it is a much bigger commitment to stay on top of all the doctors that I had to see. Before I went to deliver, I went back and did like a pre-check. They did scans, like ultrasounds of my arteries, everything to make sure that, like, I was in as good of condition as I could be in to safely carry and deliver this baby. And it means a lot more time, and it's a lot more complicated, but I can tell you that, like, if that is an option for you, it was worth the 24 times that I was in labor and delivery. It was worth the nights that I had to spend to convince them that, like, my blood pressure was fine, but you guys are panicked about it. It's definitely worth it, but it's a lot more work for the patient. And I think that's one thing that we're really working on with the vasculitis pregnancy research, is to try to make this easier for you as a patient and give you kind of guidance from the beginning, like how to approach your doctor, especially if you have doctors that may not be as excited for you about a pregnancy. And it's logical, right? Like you come to somebody and you're like, well, I'm not a healthy person, but let's go do this thing that could, potentially risk myself and now a baby. And you have to kind of be prepared mentally. And I don't think I was when that happened, because I was just like, we're going to have a baby. And I go and I'm like, this is horrible. Like this is it, and I was by myself because I didn't expect them to be like that because everybody else was supportive. And so I think you have to kind of be prepared that, like, if this is something you really want, you have to, one, be logical about it and be willing to listen to what they're telling you. And you kind of have to assess what you're willing to risk to have this baby. And I think Dr. Sims will tell you that sometimes they will tell you absolutely not, that this is just, it's a no. And unfortunately, that's some of our cases. And that's, there are other ways for us to have families if you carrying is too big of a risk, because at the end of the day, you don't want to leave your partner, your family with a brand new baby or without a baby. But again, it's definitely your decision, and you should have the power to make that decision based on the information that your team is providing you.
Yeah, I appreciate you getting into that, because I feel like what I'm hearing you say is it's possible that you'll go to some doctors and they'll tell you no. And so you seem like you're like, okay, I'm going to take in all of the information and then make my best choice from there, because it's still at the end of the day your decision. So I want to hear from both of you on this. But Dr. Sims, you had mentioned that you've sort of been talking to rheumatologists, I think, and kind of interviewing them and asking them about how they have these conversations with their patients around pregnancy. And sometimes pregnancy is an emotional subject. They can be a little bit guarded. So how do you recommend people communicate their values to their doctors so that what they really want, like that's the thing, that's the focus? And then Heather, I want to hear from your perspective how you did that.
Yeah, so I've spent the past few years interviewing rheumatologists and primary care physicians to hear how they approach pregnancy and reproductive health in patients with autoimmune diseases. And what we have found is that they typically don't bring it up, or they don't have a specific approach for patients who may have chronic and complex conditions compared to maybe, general population, people who don't have all these different considerations going into pregnancy. Also, a lot of rheumatologists are probably uncomfortable with this topic. We really don't get specific training in this area. It took me years of working with pregnant patients on a weekly basis to get comfortable. And I still encounter situations where there's no right answer and it's just a journey walk with the patient. So I think it's really important with your doctor to bring it up. Don't trust that your doctor is going to bring it up, and to be very upfront about it. Getting pregnant is important to me. How can we make that happen? And it's just like what Heather said, you're not asking your doctor's permission, you're bringing them a situation where you want them to help you reach that goal. And Heather also mentioned that, have I had conversations with patients where I say, I would be really worried if you got pregnant because of X, Y, and Z. And I recognize that having a family is really important to you. Let's look at other avenues where it would be the safest option for you. And I also encourage patients to get second opinions if they don't agree with my recommendation, to go see other rheumatologists or other types of doctors. We've certainly served as a second or third opinion for patients for pregnancy where we have moved ahead with pregnancy, whereas another physician may not have been comfortable. So you will get different answers from different people. And I would say, if they say, I don't think it's a good idea, or I wouldn't recommend that, you would say, can you be very specific about why you don't think? Probably because she had carotid involvement. And so she created her own plan to address that. She went to her vascular surgeon and vascular surgery signed off. And I bet that would make a rheumatologist feel a lot better if vascular surgery said, yeah, this is okay. We can move forward now. So being very specific with them about why they would not recommend it, and then getting into the complications. So like we were saying before, different types of vasculitis can have different complications. So if you have kidney involvement from maybe like ANCA vasculitis, and you have some permanent damage to the kidneys. Sometimes pregnancy can push you into kidney failure and the need to go on dialysis. So we always approach that topic with patients where they may need to have more medical attention after the pregnancy. And as long as they're aware of that risk of the pregnancy pushing them into kidney failure and the need for dialysis and maybe a kidney transplant, then as long as they acknowledge that, then we continue to move forward with their kidney doctor involved the whole time. And we follow them very closely. If somebody is that sick, we're seeing them every 6 to 8 weeks, assessing them, doing lab work. But also what I've seen in my research is that doctors pass the torch to other doctors. And so if you go to your rheumatologist and say, I want to get pregnant, and then they go, okay, well, I'm not an obstetrician. I have no training in this. Go to your OB. And then your OB is like, I'm not a vasculitis expert. I have no training in autoimmune diseases. Go talk to your rheumatologist. And then they refer you to a primary care doctor. So you just kind of get passed around between doctors and you get no answers. And then you either have to delay your pregnancy plans or you go ahead and get pregnant. And it may not be the most optimized situation for you to get pregnant because nobody was listening to you. And so you just kind of did what you wanted to do because that was your only option. So what I recommend in those situations is you take notes when you go to see your doctor. And then when you go to the next doctor, say, like, let's say your rheumatologist said, well, go to your OB. So you go to your OB and then they try to pass you back to your rheumatologist. You say, listen, my rheumatologist is uncomfortable with this topic. These are my medications. These are my disease complications. What would you recommend? And can you talk with my rheumatologist? Direct communication is one of the best ways to alleviate a lot of, because you become the in-between for all these specialists. And that's not your job. And that's that burden that Heather's talking about. There's so much burden on the patients to coordinate all of this care and also to like digest what a specialized doctor is saying and then regurgitate it back out to another specialist who probably wouldn't even understand each other if they spoke directly to each other because they just have different skill sets. So what I would say is like, name that. I am being passed around between multiple doctors. Nothing is getting done. I would like to become pregnant. So how can you help me from your perspective? And then what can you talk to my rheumatologist about so that we can move forward? So naming it and calling that out, because your rheumatologist and OB, they may not recognize what they're doing. They may, but they may not. And if they pass you to another doctor, say specifically, what do you want me to ask them? What is the question? What is the information that you need from them in order to move forward? Whether it's lab work, ultrasounds, just their approval to get pregnant so that you can get that information from the OB and then go back to the rheumatologist and say, this is what OB said. Now can we move forward? Doctors are, they're very much, let's create a case for why you should get pregnant. And so part of you being a patient is like creating this case of, I have all these specialists, I've had these tests done, I understand the risk, let's go, let's move forward.
Yeah, that is so helpful. Great information. I thought Heather was nodding in agreement, and people in the chat are saying 100%. Heather, I said I was going to go right back to you in this, but we're having so many questions that I want to engage both of you in the questions so that people get those answered. So I guess the first question that we got from Emily, and I guess this would be for Dr. Sims, is does your disease have to be in remission or just stable? She says, my disease is active still, but stable on, I don't know how to pronounce this, azthioprine.
It's bioprine on your end. Yeah, I see how they're laughing because we always talk about this, like remission versus, quiet disease. And so I would say, as long as your disease is stable, and the way that we define that, it's different for everybody. Again, this is just general information. Have you had a flare in the last 6 months? Have you been hospitalized? Have you needed to increase your dose of prednisone in the last 6 months? And if you haven't in the last 6 months to a year, you're on the same medicine, you're doing really well, that is a great sign. That is a sign of quiet disease that is well controlled, and azathioprine is safe in pregnancy. So you could just continue that through all trimesters. One thing I will caution people is they will feel the need to get off of all their meds before they become pregnant. And what I was talking about before is continuing those meds is actually the safest thing you can do. So we just published a study on azathioprine and lupus pregnancies, and women on azathioprine do exceptionally well. There's been thousands of pregnancies on azathioprine, no reports of birth defects. So I would say that it sounds like your disease is well controlled, and I would recommend keeping that azathioprine on board if you decide to become pregnant. And then seeing your rheumatologist maybe once a trimester at the minimum so that they can check your toxicity labs for azathioprine. So that's another dangerous thing we see is if you don't see your rheumatologist in pregnancy, who's prescribing your immunosuppression and who's checking your toxicity labs and monitoring side effects from that medication. This is a conversation we have with a lot of rheumatologists where we're saying you're prescribing that med, and so you're responsible for what happens to that medication in pregnancy. You can't just pass it off to an obstetrician or a high-risk OB. They've probably not used that med before, and they're not as familiar with vasculitis as you are, even if you don't feel comfortable with it. Rheumatologists are typically the owners of that condition, and so you have to be present at some point in the pregnancy. And so what I would say is you'll never be, typically we don't use the word curative when it comes to vasculitis, but a quiet disease for 6 months to a year is a very good sign of well-controlled disease that you could move forward with conception if your doctors are supportive.
Thank you. We've got another question. I'm going to go to Dr. Sims, and then Heather, if you can provide maybe your experience with this. So the question is, pregnancy already has a lot of symptoms. Which additional symptoms should we watch out for, and when to call our doctor?
This is a great question. And it is something we struggle with on a weekly basis in the pregnancy clinic where I see all autoimmune diseases. It's like, is this your autoimmune disease or is this pregnancy? So women who are pregnant get short of breath, going up a flight of stairs. There's one question we ask, like, can you walk 2 miles? And most of our pregnant patients are like, no, and I don't want to. So stop asking me that question. So it's not pathologic. It's not something that's wrong with them. What I would say is knowing what your flares have looked like in the past. So like in Heather's case, maybe if she starts noticing numbness or tingling in her arm or in her leg or dizziness or passing out, those kinds of things. So anything that mimics a flare you've had in the past that you were experiencing in pregnancy could potentially be your vasculitis activity. What becomes tough is lab values become less reliable in pregnancy. So inflammatory markers, things like ESR and CRP, we typically rely pretty heavily on in vasculitis to see if they go up or down. In pregnancy, they both tend to go up just from the pregnancy itself, not because there's any active inflammation. So I would be cautious if your doctors get those labs and they're higher. I wouldn't panic because it could just be the pregnancy, but you could look at the number differences. So if it's a slight increase, then maybe it is the pregnancy. If it's a huge increase, then that maybe we should talk about additional like imaging, like maybe an ultrasound or a CAT scan, which in very desperate cases, I have gotten CAT scans on patients in pregnancy to look for things like blood clots. So what I would say is typical signs of your flares. And then things like fevers, never normal in pregnancy. Things like numbness, tingling, weakness, passing out, not normal. Things like feeling your heart racing, drenching sweats at night where you're having to change your clothes. These are all typical signs of inflammation that could be related to your vasculitis. If you've had kidney involvement, if you have blood or bubbles in your urine, that could be indicative of active kidney disease. Or if you are coughing up anything, also not any blood, not normal. Now, nosebleeds can happen, but coughing up any blood, especially if you've had lung involvement. And normally when we talk about shortness of breath, we say if you cannot climb a flight of stairs comfortably, then that's when I would call your doctor and say, like, listen, this is not normal for me. That's typically Dr. Close is my mentor. That's typically the threshold where we start to do some lab work to look for anything abnormal. Swelling in the legs, that comes on really quick. I've had a few patients show up and they're like, my legs look like tree trunks and I've gained 8 pounds in the last 2 days. This is a true story. And she was preeclamptic. We had to admit her to the hospital that day and she delivered twins by C-section that day. She didn't have vasculitis. She had a different autoimmune disease, but rapid weight gain, swelling in your legs, and then anything that mimics a prior vasculitis flare.
Thank you. Heather, did you experience any of this and have to make those like discerning decisions about what it was?
So most days I can't climb a flight of stairs without being out of breath. That's just part of being sick half the time. But you're normal. And I would say when you're pregnant, anything that is not normal, you can call the nurse's line. And when you hit a certain point in your pregnancy, you then get to go to labor and delivery instead of going to a main emergency, at least at the big hospital that I'm at. And so then you can call them. And most of the time, the answer is, we need to see you. I was very sick. With my second pregnancy, not because of anything wrong with me, but because I had a child who went into kindergarten and he brought home everything. And my immune system is just there waiting for anything. And I had respiratory infections pretty much my entire pregnancy. It was rough. I was in the emergency room a lot. And sometimes it was nothing. It's the same way. Preeclampsia, I think, is probably your biggest threat for people with vasculitis. And that's the most dangerous for you and your baby. And so they were constantly monitoring me because, again, my blood pressures, they struggle to look at. And so anytime there was like a little bit of an incline, they're like, off you go to be observed for 24 hours. And again, that's just something you have to accept as a person who has a lot of complications. And I had already accepted that in my head that I was going to be in there a lot. And I think that made it easier for me because my attitude was just like, well, I'm going to go hang out with the labor and delivery people. And I mean, by the time I delivered and I was hospitalized both times for, I think, 10 to 14 days before I delivered, just because they were like, we would rather you be right here where we can see you, because the preeclampsia risk is just so incredibly high that they're like, I don't really want you out of my sight. And I was actually happier that way because I'm a professional patient. I know my body, but this baby, I do not know. And that was kind of the thing with having to work with so many people is it's like, I would go to my OB and I'd be like, here I am. And she's like, well, your blood pressure's high. I'm like, that happens sometimes. And it's like, nope. And I'm like, okay, you got to do what you got to do to make you feel better. And I am along for the ride because I think the most important thing is find a doctor you trust. I did not always like what she had to say. I did not always want to go to the labor and delivery and sit there for 24 hours when I was uncomfortable and I just wanted to be home. But I trusted my doctor to make the right decision. And when there came a point where my blood pressure spiked at like, I think I was 34 weeks. She's like, we may have to deliver this baby. And I was like devastated. But at the same time, I was like, you guys do what you need to do because I know that you're here to keep me and this baby safe. And I don't know enough about my body and how it's going to handle this pregnancy. And while I'm pretty sure my blood pressure is not causing problems and it's just me getting excited, I trusted my OB and we waited him out, thankfully, and she also had to trust me. And the second pregnancy was much easier because I had the same OB. The first pregnancy was like us figuring each other out and me figuring out when I needed to speak up, because there were times, the first time I went in for a blood pressure issue, they were like, we want to give you something to dump your blood pressure. And I was like, you can't do that because I don't have blood pressure going to my head, and you dump it low enough, I'm going to start passing out, which is not good for anybody. And so I really had to stand up and be like, no, you can't do that. Or and in that case, it was, I need you to call my cardiologist and check with him. And oftentimes they would call my cardiologist. The cardiologist would be like, we know her blood pressure goes up and down. She's okay. You guys just leave her there, give her a little bit and she'll calm down. And so that's when it comes to having that entire team of everybody around you, because I did have issues. At one point, they scanned my carotids to go check before I delivered, and they were like, something looks a little bit weird. And so then I had to have an additional scan done. And that was because I told them, like, if you're originally they wanted me to vaginally deliver my baby. And I was like, that's fine. But if you're going to have me push and do all that stuff, I need to make sure that I have blood flow, because when I push down, I don't want to be passing out during delivery. And so I really had to advocate for that. And I think that's what you have to realize is that we're really working hard for you guys to like mend this kind of relationship and make it so that the rheumatologist will help direct things and things will be directed for you. But the reality of the situation right now is that you have to do a lot more legwork to keep your entire team involved. And it was me being like, and it's not because that your doctors don't want to take it over, but it's because they don't know. Like my high risk OB doesn't know that like I really should go check with the vascular surgeon, or my cardiologist knows my blood pressure. And so he's a person who can help chime in. And so you have to kind of have your playbook of doctors and be like, okay, this is being weird. I would rather go look like, I think one of the things was you can get like a murmur from the excess blood flow. And when they noticed it at a primary care visit, she's like, it was actually like a med student. He's like, you have a murmur. And I'm like, oh no. I stepped back and I was like, okay, I like messaged my cardiologist. I'm all panicked, and he's like, it's fine. Come on in. We'll get an ultrasound. So I had like an extra ultrasound of my heart done. They did it again before they cleared me just to make sure that it was like a pregnancy murmur from the excess blood flow. But again, like you can't just be like, oh, great, I have a murmur. No big deal. It's probably just like every normal person gets when they get pregnant. You have to really be like, that's fine for you guys not to panic with like a normal person, but I'm not a normal person. I'd like to get the rest of my team involved. And they're always more than happy to. I had so many appointments. It's a full-time job when you're pregnant on top of the job that you have. And when you go to have a second one, you then have another being that you're also taking care of. So like that is one thing when you go to have a baby, you have to be prepared that like you have to be fully engaged and involved. And you can't just be like, they're going to handle all of this because they're doing the best that they can, but everything's not in their wheel well. And the system is not yet designed to manage the pregnancy for you when you have like 20 different doctors. And again, that's what I think Dr. Sims, we're really trying to work on, like educating the doctors out there that like this is a huge burden for somebody who's already very stressed out, very tired, very pregnant, and worried. And on top of it, then having to like really try to be a doctor almost and be like, who do I call? But at this point, that's kind of what you have to do to really ensure that you're getting the best care for you. Because like Dr. Sims said, if you're not doing well, it's going to be harder to have a baby that's doing well and have a successful pregnancy and, a good outcome. Like it really is your responsibility at this point to kind of manage yourself and your doctors, which is a lot.
Yeah, I appreciate that advice. And what it sounds like is, as a professional patient, as you said, you have to be vigilant and report things that you're noticing and speak up for yourself. I also love the word used a few times, trust, like having that trust with your doctor, finding that person that you can trust. And then you mentioned something else that someone had a question about. So she said she has CNS vasculitis. She's in her 10th week of planned pregnancy, and she's thinking about delivery. Is natural childbirth or cesarean section recommended? It's sort of what you said, Heather, kind of like she's worried about the physical tiredness and inability to perform like the physical function of performance of giving birth. Dr. Sims, do you have any thoughts on that?
Yeah, that's a great question. And it's certainly something that we run into. So typically what I say is it kind of depends on the CNS vasculitis and the disease course that's happened before and the prior damage. Normally, I get a anesthesiologist, a cardiac anesthesiologist involved and have an anesthesia plan for the pregnancy before labor is even a thought. Having a plan going in is going to make everything a lot smoother. I would also recommend that you deliver at a level 1 high acuity hospital if there's one close to you. Sometimes if you're in a community hospital, they won't have access to certain types of doctors. And if there's any complications with you or the baby, there's a time lapse. They may have to like fly you to another hospital. So delivering at a high acuity hospital is very important. Talking to anesthesia. For CNS vasculitis, if you have a neurosurgeon or neurovascular surgeon, a neurologist, on top of your rheumatologist, getting all of their input on increased what we call intracranial pressure. So when you are pushing down to have a vaginal delivery, there is increased pressure in the brain. So something I always ask the neurospecialist is, what are the risks involved with this person delivering vaginally? And is cesarean delivery something we should consider for her safety and for the safety of the baby? Our data shows that women with any autoimmune disease have a higher chance of delivering via C-section. This can be because of complications, but it's also because it gives the doctors more control over the delivery itself. The goal is always to have a vaginal delivery if it's possible, but sometimes with a complicated condition like CNS vasculitis, they may want a little bit more control. And so the risks of a cesarean delivery do not outweigh the risk of going into a vaginal delivery, not knowing the potential complications. So I think it's a very valid question and something you should ask all the doctors who manage you, and ask that they talk to each other to come up with a collective plan. Because I've had patients deliver vaginally who have had intracranial issues where the anesthesiologist or the neurologist reviews the MRIs and says, oh yeah, I think it's completely fine and safe for her to move forward with a vaginal delivery. So that's always a possibility. But it's case by case, and you would want someone who's seen your scans, who knows your body, who knows your disease, to make a decision about the delivery.
Sorry, it looks like I'm getting a delay on the sound. And so that's why I'm sitting there for a moment. And so that's why I'm sitting there for a moment. Sorry, now I'm hearing my voice repeat back. So let's see if we can get through this without
I'm hearing my voice repeat back. So let's see if we can get through this without
that too? Are you hearing that too?
Yeah, there's a delay.
I don't hear an echo.
Yeah, there's a delay.
Oh,
I only hear Ashley's echo. I only hear Ashley's echo. Oh, now mine.
Let's try this question.
Oh, now mine.
Can Dr. Sims try this to a rebound effect of disease activity following birth?
Was that for me?
Yeah.
Can you guys hear me? Yeah. Okay. So flares postpartum, is that the question?
Yeah, it's a rebound effect of disease activity. So flare, yeah, after birth.
Yeah, it's a rebound effect of disease activity, so flare, yeah, after birth. So what we found is that in autoimmune diseases, typically a third of women will flare after delivery. It's different for each autoimmune disease, and that's really what we found in our vasculitis population from the pregnancy registry. So I have two approaches to this. The first is that if you continue your medication throughout pregnancy, your risk of a flare after delivery is lower. So continuing medications and then having a plan for a postpartum flare. So I typically call this like a pill in pocket approach, where I will give a patient prednisone to keep in their medicine cabinet at home, so that if they flare, and whatever that flare looks like, if they flare, we have a prednisone plan in place in order to bring that inflammation down quickly, and then they call me if they have a flare. Some women may have to restart medications that they stopped for pregnancy, or may have to start additional medications, but I don't find that to be the typical case, at least in my practice. We typically will do a little bit of prednisone, and then once the hormones level out postpartum, most people go back to where they were before, but some women will have like arthritis as part of their flare. And so we want to make sure that they can breastfeed if they choose to, they can change baby's diaper. You're already not feeling your best, lack of sleep, you're recovering from a major traumatic medical event, which most people don't recognize at birth, but it is. And so your body's been under a lot of stress, there's a lot of hormone changes, those things can flare vasculitis. So having a postpartum flare plan in place with your rheumatologist or your kidney doctor, whoever manages your vasculitis, is the way that I approach that, so that you don't have to call them in the middle of the night and say, I'm flaring, what do I do? Or then go fill a prescription at a pharmacy and then have to go to a doctor's visit. It's just a lot of extra steps.
Someone else asked about research. So I'm hoping, Dr. Sims, you can talk about VPreg.
So yeah, this is our Vasculitis Pregnancy Registry registration page. This is like our one pager on what it is and how you can register. So this is for any patient in the world who is currently pregnant and has been diagnosed with vasculitis. This QR code on the right here will take you to the registration page. It's all online and it's all patient reported. So your doctor does not have to do any additional work. And basically what we're trying to understand is how women feel and function with vasculitis during pregnancy. So each trimester, you'll get an additional survey. You'll do a baseline survey, a survey each trimester, and then a postpartum survey. And we ask things like, what medications are you taking? How are you feeling? Has your vasculitis flared? How does baby look? Are baby's ultrasounds normal? Are baby's labs normal? Are you needing to be hospitalized? Are you having any complications at all? And we take this information so that we can educate women with vasculitis and give them cold data reported by patients who have vasculitis, which is such a rare condition. A lot of our information comes from lupus because lupus patients tend to be a little bit younger at diagnosis. So a lot of our data comes from lupus, and while it's really wonderful data, it's best if we can get vasculitis specific data. So it's for any adult patient. It's a few online surveys. And like I was saying before, yeah, these are just the different things that we ask you. And Heather and I have been working on this for years now. We have videos online. If you go to the vasculation of this QR code, there's different patient resources. So we created a handout on birth control, a handout on pregnancy. There's also a little section on male vasculitis patients in pregnancy. And there's a few videos that answer disease-specific questions and other frequently asked questions about pregnancy. So we love to recruit patients to get involved so that we can encourage other patients to pursue their goals. Becoming pregnant as part of that. We want to reduce between controlling your vasculitis, but then living the life you want to. We want you to live the life you want while having vasculitis and being healthy and being happy. So that's kind of the goal of VPreg. We have more than 200 women registered in 20 different countries. And Heather has had 2 pregnancies through VPreg. So she is a person who's done it twice, which is great. And we continually have people all over the world that are registering, and it creates a great community. And again, it creates data so that we can give women more information to make informed decisions.
I wanted to ask you about that community part. Oh, I'm echoing. Someone had asked us about if they are looking to get pregnant in the future, can they, Dr. Sims, I don't know if you and your team, they can reach out to for care if they're in the area, or if there's, they can get in touch with you either generally, both of you, get in touch with you if there's a community they can reach out to for support.
Yes. So Christine Young is our research coordinator, project manager. She is really the driving force behind VPreg. She organizes everything, very responsive. She will escalate things to myself. And the VPreg was founded by a vasculitis expert, Dr. Peter Merkel at the University of Pennsylvania, and Dr. Megan Close down here at Duke, who's a pregnancy expert. And so we want to answer questions and give women access to information that they may not receive where they're at currently, because they may not have access to certain specialists who can give them that information. So if you're thinking about becoming pregnant, you have questions, you want resources, Christine Young would be and her contact is on that QR code that we had on the prior slides. Oh, there it is. Thank you, Jennifer. And I was just at a Vasculitis Foundation conference a few weeks ago with some of you people here in Nashville, and community was such a big part of people not feeling isolated, not feeling alone, not having to turn to social media for information, like good, high quality resources. And Heather and I are working, we're using grant funding in order to create a better community, interventions, different ways to support these women so that they feel informed, and I hate to use the word well supported, but a community that really supports them so that they can feel comfortable in their decisions, but then also meet people like Heather who have lived it, and not just their doctors being like, yes, I know how you feel. And you're like, no, you don't. You don't live this. You just know about this disease. It's helpful to watch other people who have been through this and have lived pregnancy.
I know we're coming to the end now. I want to see if we can fit in another question. So someone else asked about birth control. So say you're wanting to plan your pregnancy, you're not ready yet. Are there certain birth controls that are best while on certain medications like methotrexate?
Great question. So the number one rule about birth control and medications, I do not recommend oral birth control pills when you're taking mycophenolate or Myfortic. There's an interaction between the two, and then the birth control becomes less effective. So if you are on anything that contains mycophenolate, I try to avoid oral birth control pills. But my top 2 recommendations for contraception are IUDs. You can do hormonal IUDs. You can do copper. The copper one can last up to 10 years and also can function as if your primary birth control fails, it can kind of work as a plan B, so an emergency contraception. So copper IUD. So IUDs are the most effective form a birth control followed by an Nexplanon or a subdermal implant they put in your arm. Those are extraordinarily effective. Also, partner vasectomies, which if you're planning on a pregnancy in the future, not ideal, but if you're not, very, very useful, very effective, and underutilized in my clinical experience. But there are lots of options. And I would say when you're trying to choose a birth control, knowing if you've had a blood clot before will limit your birth control options. So we typically try to limit or avoid estrogen in patients who have had blood clots. So that's really important. And then if you've ever been diagnosed with an autoimmune disease called antiphospholipid syndrome, which is not very common in vasculitis, but if you have been diagnosed with APS, we avoid estrogen in those patients as well. So, and just as a side note, knowing if you've had a clot or not will also impact infertility treatment. So assisted reproductive technology, if you undergo any type of ART, knowing if you can be exposed to certain hormones is very important, and knowing if you've had clots in the past can affect that.
Thank you. And you've all been so engaged, and like I said, thank you for your questions. We'll have to see if we can follow up and maybe do something like this again, because I know there was a lot that we didn't get to answer. Dr. Sims and Heather, I'm so grateful for both of you, and Heather for sharing your personal experience and reminding people that this is possible. And of course, Dr. Sims for all of your really good insight. Once again, I just want to thank our sponsors who make this possible, Amgen, Novartis, and AstraZeneca. Thank you all for coming, and of course, thank you, Dr. Sims and Heather.